Welcome to The Gut Show. I'm your host, Erin Judge, registered dietitian and founder of Gutivate. I'm also your fellow IBS warrior. Our goal on this side of the internet is to empower those with IBS and digestive disorders to understand their gut better, to have a healthier relationship with their bodies, and to make confident choices to improve their digestive health. During this season, you can expect a conversation around a hot topic related to gut health, digestion, and IBS. As a disclaimer, I am a dietitian, but I am not your dietitian. So everything covered in this episode is meant to be educational and is purely information that you can take back to your healthcare team in order to make the best decisions for you. If you're new here and something just doesn't feel right in your gut, if your symptoms have led you to this podcast, I invite you to start by taking the quiz, What's Your Poop Personality? Your personality type will unveil what your symptoms may mean, what may be causing them, and what you can do about them. This is a free quiz and you can take it today at gutivate.com or find the direct link below in the show notes. While you're going to take the quiz, let's jump into today's episode. Now for a quick word from our sponsors with resources that might support you. Did you know that you can now order your own gut health tests without waiting months for a doctor's appointment? Gemelli Biotech offers trusted, science-backed, at-home tests for conditions like SIBO, IMO, ISO, and post-infectious IBS. Their Trio Smart Breath test measures the 3 key gases, hydrogen, methane, and hydrogen sulfide, to detect different forms of microbial overgrowth. As for those with IBS symptoms, IBS Smart is a simple blood test that can confirm post-infectious IBS with clinical accuracy. Validated by the leaders in gut health, these are tests that you can trust and tests that you can take comfortably from your home. So go to getgutanswers.com to find out which tests are right for you and use the code ErinJudge25, all one word, ErinJudge25, to save $25 on your order. Is a gluten-free diet just not cutting it, or maybe not even necessary when it comes to chronic symptoms like bloating, gas, and pain? Research actually shows that in those without celiac disease, it's actually the FODMAP, the carbohydrate fructan in wheat, not gluten, that causes symptoms most often. This means that you may not need a strict gluten-free diet to see symptom relief. And it means that if you are reacting to fructans, there may be more foods in your diet beyond wheat that are causing you symptoms. This includes foods like garlic and onion, and even some fruits and vegetables that can sneak their way into your diet and contribute to those chronic symptoms. So you can choose to limit these foods and reduce your overall fructan intake in order to avoid symptoms. You also have the option to break the fructan down using FODzyme, an enzyme blend that targets fructan, lactose, and GOS FODMAPs, and that will help you break these FODMAPs down to then prevent the symptoms. Learn more about FODzyme in the show notes, and you can use the code THEGUTSHOW for 20% off your first order. And now let's get back to the show. Kate Scarlatta, who's a dietitian in the IBS space. I know Dr. Pimentel, she always refers to you as like the maverick in GI and in the functional GI world, because you've been such a big advocate for IBS research, going a bit deeper into like why symptoms are happening versus only symptom treatment, which I know patients have really appreciated. And you have definitely been a patient advocate as a researcher and as a physician, which unfortunately is kind of rare. And so I thank you for your work that you've done. I know everyone here is probably joining me in that thanks. And I'm excited that you're here today. So thank you so much for being here.
Nice to see you, Erin. I'm glad to be here. Thanks for the introduction.
Yeah, I'm so excited. And I've got questions. We already have a bunch rolling in. And my first, I think, just for us to kind of set the stage a little bit and get a little bit of background information out of the way, can you give a brief rundown on what SIBO, IMO, and ISO, what all of this is and your role in this kind of microbial overgrowth space?
Yeah, I mean, look, in 1996, when I first started my fellowship, the word microbiome hadn't even been created. That didn't come till 2003, 2007, depends who you talk to. So we had a bit of a challenge when we were saying that, well, let me state it another way. IBS and bloating. One of the problems we've had with IBS is that bloating's never been part of the Rome criteria. And despite attempts to lobby to get bloating to be part of the Rome criteria, and despite Rome's own data saying bloating is the most important symptom, it's not there. So when patients are saying bloating is the most important symptom and the doctors are saying, no, it's your pain that's the most important symptom, we're already creating a wall between us and our patients. And this is something that's very frustrating. But bloating is where it all started. And so why are you bloated? Why is there gas being produced in the gut? And this is an interest that I took in 1996. But what I didn't realize is we'd end up with three different microtypes of IBS, where there's three different gases, three different basically environments of bacteria that can have such dramatic effects. One of the so you mentioned IMO, ISO, and SIBO. Well, it all started with SIBO, and that's the order in which this was discovered. The first breath test was just hydrogen. And now that I think about, almost 15 years, 20 years, maybe longer of just hydrogen and how naive we were, because hydrogen is being used by these other two gases. So you can't even rely on the hydrogen number all the time unless you know all three. But here we are. SIBO was the first. And SIBO is basically an overgrowth of bacteria in the small intestine. But now we know in 2025, it's not your grandpa's overgrowth. It's not the overgrowth that we used to talk about in the 60s, 70s, and 80s, because in specifically IBS or in the SIBO we're seeing now, it's just E. coli and Klebsiella. It's not the colon bacteria moving into the small intestine. And when the breath test was then pushed to add methane, by Quintron was the original company that did that, they didn't have any data to say methane was important. Just, hey, now we have a machine that measures methane as well. And we soon discovered that methane was associated with constipation, and that became intestinal methanogen overgrowth. And it isn't until like the last few years that we discovered that hydrogen sulfide is what's causing the diarrhea. And we now know those characters. I know it's a long answer, but there's sort of a history to getting to this point where we now know all three gases, and we're able to see the microbiome entirely with shotgun sequencing, and we can get into more details on that as we go through the hour. But we now know the players, the gases, and how it dovetails with the patient's complaints and what we see in clinic.
Amazing. And I like that you went into that background because I think it helps a lot of people that are in this room. I was diagnosed with IBS 20, 20 years ago now, 22 years, that's a very long time. And I think that for a lot of people, their diagnosis or symptoms, starting 10, 15, 20, 30, even 40 years ago for some people, understanding the research that we may now have to help people understand what could be going on and what to even bring up with their doctor today versus what they talked about 10 years ago is very important, because that's the whole point of science, is to understand things over time and then be able to use that as patients too. With the testing part, because I know that that's going to be a big part of the conversation. Do you, with the research you've done and where you stand today, do you think everyone with IBS, if you've gotten the diagnosis at some point, you should do the breath testing and see where you're at? Are there certain symptoms or people groups or history that you would say definitely, like if you meet this criteria, you should go through testing? And what test would you recommend if someone's wanting to see if SIBO or microbial overgrowth is part of their picture?
I would answer it slightly differently in the sense that, let me give you an example. I had a 25-year-old female. I use this example often because it's an extreme example, but it's not uncommon. So she came to the office and I was taking the history, and she sounds like IBS, very classic, all that sort of stuff. I would have made that diagnosis. I would have done a breath test and then move on. And then I said, have you ever had a colonoscopy? And what did they show? And she said the colonoscopies were normal. And I said, you're 25. How many colonoscopies have you had? And she said, three. And I said, and all three were normal? And then I got into the details and I said, well, why did the first doctor do it? Well, we got to rule out Crohn's disease. Well, I could have said she doesn't have Crohn's disease just from my history. And then I said, well, what did the second doctor say? And she said, well, we take biopsies from special locations. I'm like, I don't know that special location. Were you taking a biopsy of the appendix? I'm confused as to what you're talking about as a special location, because I do colonoscopy as well. And then the third gastroenterologist should be written off because that's just ridiculous. After two negatives, this is just abuse of the patient and risk, right? And so my when you ask the question, if you have IBS or suspected IBS, should you do a breath test? It's extremely cost effective to do a breath test, because if you do a breath test, as in a 25-year-old patient, doesn't have to be female, male, whatever, and you find a positive and you know the gas type, you know what treatment to use, I can tell you Crohn's does not respond to antibiotics like this. Celiac does not respond to antibiotics like this. And if a person comes back 80% better from starting with this, you're done. I mean, you don't need to look for other things. You don't need to get the colonoscopy and go through all that expensive testing, not to mention, how it could be hazardous to you, to your health. You can have a perforation. So, yes, and it's not me saying this, it's new guidelines that are coming out, because the data in the last 4 years has been so overwhelming that SIBO and IMO are part of IBS, that some international guidelines are saying that you have IBS, you should think of this. And we're not saying that SIBO replaces IBS. That's not what we're saying. We're not saying that H. pylori replaces peptic ulcer disease. We're saying that in a 60% of IBS patients, it could be SIBO. Treating it this way will make a patient more better, if that's a term, than other things. And so you're stratifying your patients. The other 40%, negative on the breath test, negative. You can try, some of the conventional therapies, but at least you streamline 60% of your patients.
That's great that guidelines are starting to reflect that. I think that'll help because patients always ask me, as a dietitian, I don't run a lot of tests, so I'm not running a SIBO test or diagnosis. It's not really my role. And so if I'm working with a patient and they want that, if their doctor's turning them down for doing the test, it's nice to have something that they can hold on to beyond the SIBO ACG guidelines that were very helpful, like now
Yeah.
having more guidelines in the IBS space. You mentioned like the shotgun sequencing that you use in research. And then we also have the biopsy that can be taken through endoscopy that's been used for SIBO, like diagnosis in the past. We have the breath test on the market. You already mentioned that if you don't have all the gases, the breath test might not be helpful. How should a patient navigate testing and know maybe which approach is right for them, what's coming out soon? What are the options going to be?
This is how I practice, so I don't want to, pass judgment or be too emphatic. And we are involved in some of these companies, which is full disclosure, because we have to. I'm not Walmart. I don't sell stuff. I just do the science, but we have to pass this on to somebody else to actually get it to the world. And so, but the three gas breath test, in my view, is the only breath test, because now, and part of the reason I say that is what we're going to present at DDW, because this is the most validated breath test and will be the most validated breath test ever, because it's the first time ever we've done a breath test and compared it to shotgun sequencing. So we know that this three gas breath test, the gases are not just there, they are telling us exactly, or with some precision, how many of those bacteria that produce those gases are in your gut. And so we know that it's proportional to the amount of hydrogen sulfide producers in the gut. If you measure hydrogen, when you measure hydrogen sulfide, how many methanogens are in the gut when you measure methane in the breath. And so while people have criticized breath tests over the decades, it isn't until the last 3 years that we say, no, the breath test is precise and it is able to quantitate those bacteria in the gut. So I do a breath test in all my patients, and it's a three gas breath test. And so I think that's the starting point for patients, from my view, with IBS. And then you move on to the treatments and the other things but shotgun sequencing has told us so much about who the characters are in the gut.
Like we don't need that like for patients because the breath test is becoming so validated compared to this test.
Yeah.
The role of maybe microbiome type testing in the future, like through stool or some version of that in a consumer way, that may not be necessary because the breath test is showing so accurate compared to that, correct?
Right. So I don't like to knock other companies or other products, because it isn't, it's sort of like, do you use natural products in treating IBS? I do. I do sometimes use natural products in treating IBS and SIBO. And some of those products don't have good data out there because nobody has the money to study them, but yet they work. So it's the same thing for stool testing. These companies that do a lot of stool testing, at the moment, I'm not sure that what they find or how they find those things definitely correlate with what we're talking about here. But it doesn't mean 3 years from now they won't have data to say, no, it was. You know what I'm saying? It's sort of like what we're doing. We're continually proving the story. But what I can tell you is that if you do a stool test for the microbiome, which is very popularized these days, it can't tell you what's in the small bowel. The small bowel is radically different than the colon. And we believe that the majority of the problems we're seeing related to IBS are more small bowel related. So if you can't get into the small bowel, you can't see the bugs of the small bowel, your only choice is a breath test at the moment, unless, some of these capsules or other sampling techniques will come. I have a problem with the capsules. I think that the capsules don't necessarily open where I think they open. I have a problem with the capsules in that you're going to swallow a device that could get stuck. I have a problem with the capsules as in they're expensive. So unless they get them cheaper, validate them more comprehensively, we've got breath tests for quite a while to go.
Wonderful. And someone did ask for clarity, what is shotgun sequencing? I'm sure other
Um,
people may be wondering that as well.
couple of words, shotgun sequencing is very expensive, but that's not an explanation of the question. Shotgun sequencing is basically taking a sample, whether it's stool or in our case, small intestinal juice when we scope patients as part of the Reimagine study. You take the juice, you extract all the DNA from the juice, then you got to remove all the things, DNA in there that's human, of which it's about 90% because it's in you. And then you take the remaining 10% and you sequence every single bit of DNA in there. And then using library techniques and then comparing that to databases, you're able to say who the bacteria are there, how many of each are there, and so you determine the exact composition. Now, we can see with shotgun, we can see bacteria, we can see fungus, we can see parasites, and we can see viruses. So we see everything. We can even see what you ate because we can see the DNA from celery, we can see the DNA from pork, we can see the DNA from cannabis if you happen to be ingesting cannabinoids. So we can see a lot from shotgun sequencing, but the point is it's maximal comprehensive assessment of what's there.
Before we get into like causes, because I know this kind of ties into that of what you've discovered there, and then treatment, we do have a few questions specifically on testing that I think are really interesting. And there's two that are similar. What if you have a negative test, but your symptoms all line up? Can you still have SIBO? And then another one said, what if you also have high methane, or you have a positive breath test, but you don't have any specific symptoms that line up with that? So negative test, but symptoms are there versus like a positive test where symptoms are not there. How do you handle that?
Or like I said, there's about 40% of IBS patients who test negative. So we can't make the assumption they have SIBO. You could empirically treat them with rifaximin because that's how we used to do things. We never did a breath test first. And so you could empirically treat that patient and see if they got better. But the chance of somebody getting better from rifaximin if their breath test is negative drops precipitously. And we've published that paper. So yes, there is a chance. There's a 1 in 4 chance you might still get better with rifaximin if your breath test is negative, but there's a better than 50% chance you get better if it's positive, and a greater than 75% chance you get better if that rifaximin makes the breath test become normal. So a negative breath test tells you likely you don't have SIBO, but you still might respond to rifaximin. It's unclear, but the chances are lower. On the positive breath test front, in terms of healthy, there's sort of two ways to look at that. It's like every test we ever had or have ever developed in medicine. Healthy people sometimes test positive on tests for cancer. Healthy people sometimes test positive on tests for, et cetera, et cetera. So the same thing with breath testing. There are people who are healthy who the test comes back positive. And so I think you need to just take a better look at that patients. Like I have patients, for example, who came in and they have a breath test and they come in with their breath test and say, you know what? I said, what's your bowel habit like? Oh, it's normal. but you have an abnormal breath test. What's your bowel habit like? Well, it's been normal. And I said, well, what does normal mean? Well, I wake up in the morning and I have a bowel movement, and then 3 hours later I have another bowel movement, and then 3 hours after that I have another bowel movement. And I said, well, what does it look like? Well, it's been like this for 15 years. I said, yeah, but what does it look like? And well, it's sort of mushy like mashed potatoes. And then when you get into the details, the patient thinks, because they're not walking around looking for other people's stool to see what it looks like, that they're normal, but they're not, and they really are not, and they're mild. It's not bothering them so much, but they're not normal. And what I tell patients, and this is gross, but I'll tell patients that walk down the street, your street, and I bet you if you walk 3 blocks, you'll see some dog feces on the grass. Look at that feces. The dog never wipes itself. And that thing just falls down. It's firm. It's got cracks, crevices. You can look at that and say, "Does my stool look like that?" And the answer is probably not. That's one possibility. But there are people who are truly normal. I forgot to say one thing about patients who have a normal breath test but who have symptoms. There is a distinct possibility you have a normal breath test because you used glucose and not lactulose. So you have to be careful when you do breath testing. We always do lactulose for our patients, but there are a lot of doctors out there who swear by doing glucose. Glucose is more specific. If you have a positive glucose breath test, no doubt you have overgrowth, but it misses some of those patients. So that's something you need to focus on as well.
Is the Trio Smart brand of breath testing, is that the only one still that currently does the three breath, or is there any others on the market that you know of?
Right now, it's just Trio Smart. There is no other breath
Okay.
test that does 3.
Okay. And with that one, because I know patients can order that one directly, and we don't have to get
Okay.
into all of that specific. So I always like to say, it's good to have your doctor on your team, because if you have to treat it, you want a good doctor on your team for that. But with the solution you mentioned, I think glucose is what comes with it normally. And I think you have to get prescribed lactulose, correct? So would that be something they need to make sure that they specifically ask their doctor for?
Yeah, it's a single dose of lactulose, 10 grams. Super easy for the doctor to call in. But yes, you need a
Okay.
prescription for the lactulose. That's a very important point. A breath test of lactulose always needs a prescription. You can't get lactulose without a prescription legally. You're not supposed to, anyways. So the test has to follows the regulations, and so the doctor has to order the lactulose.
Okay, perfect. And hopefully those guidelines you mentioned, or just having more information, again, that's something
Mhm.
patients can take to their doctor, work as a team with their doctor, and ask for those specifics. Let's talk a little bit about cause. And I know, you've talked about, and I would love for you to go over like foodborne illness, kind of gut infection with SIBO and overgrowth. There's some people have asked, like, do certain medications cause it? I know you guys looked at PPI use and cause. Like,
Mhm.
what is the current update on like what actually causes these overgrowths in patients that then leads to these symptoms?
What we've determined now, and this is extremely clear, is that food poisoning leads to IBS. So you have food poisoning at some point in the past. You developed antibodies to the nerves of your gut. The gut then doesn't clean itself properly, and then you get overgrowth. So we believe that is the cause of IBS. It's not previous antibiotics that we can have ever determined. You mentioned proton pump inhibitors, acid inhibitors. There's, again, your grandfather's SIBO is that if you took acid suppression, there's not enough acid in the stomach and bacteria from the mouth is getting into the small bowel and causing SIBO. We don't find that. In the Reimagine study, we looked at people on PPI, we looked at people on different types of PPI. There is no SIBO from taking PPIs. And I sort of, you sort of think about this. How often do you have to wash the dishes in your house? Once a day? Once? How many minutes do you need acid at pH 1 to be around to kill the bacteria that are in the area? 5 minutes? 10 minutes? I think so. So PPIs don't get rid of acid altogether. They just get rid of it most of the day. So I think that's why we really just don't see SIBO in people on PPI.
Wonderful. And then someone asked specifically about calcium channel blockers,
Right.
like, and maybe some
So
other medications.
Yeah, that's a very good question, and it dovetails with a lot of medications because the one medication we know absolutely for sure will make you have SIBO is narcotics. So if you're on morphine, Dilaudid, and any of the narcotics, there were studies done in the 1990s where if you just give normal people narcotics for 2 weeks, they'll get SIBO because it's blocking the cleaning waves of the gut. But calcium channel blockers, not so much. It really doesn't inhibit the cleaning waves of the gut that we've seen. Beta blockers is another category of heart drugs that do sort of slow you down, but they don't slow down the cleaning waves. So that also is not going to cause SIBO.
Wonderful. And have you guys looked at this is more of a question for me, but I know some others may be looking at this as well. I know in the IBS world, we're looking a lot at mast cells, which are immune
Mm,
cells, and then the role of histamine in the functional medicine space. I know histamine and SIBO is also like really highly talked about. I know you've talked previously about that role of kind of the immune system and the
right.
sort of autoimmune like nature to that foodborne illness to overgrowth pathway. Are you seeing any relationship with like mast cells specifically, or like anything going on there? And then I'm thinking also like endometriosis patients, maybe our IBD patients, people who do have these other immune conditions, that there might be some correlation to SIBO, like that may not be as clear as foodborne illness. Like I'm curious your thoughts on all of that.
Yeah, so the mast cell story, histamine, eosinophils are all evolving. The Australian group seems to find higher levels of eosinophils also in the small bowel or duodenum in patients with IBS. So again, this is not your grandfather's SIBO. And when I say that, I'm not being derogatory. What I'm saying is we now know the cast of characters. So in the case of SIBO, the two characters that are overgrowing. It's not colon bacteria, it's E. coli and Klebsiella. Klebsiella happens to be a very high histamine producer. So when patients say, "Oh, I can't eat that food because I get a allergic response or I get a reaction to it," it could be that you're feeding Klebsiella, it's producing extra histamine and you get a histamine-like response. I'm not saying that's what's happening. I'm saying that can very possibly happen because Klebsiella produces a lot of histamine. That histamine can also recruit mast cells, eosinophils to the lining of the gut if there's a lot of histamine in and around the duodenum. So we're already looking, and some of this will be at DDW, so I can't talk exactly about it yet for another 4 weeks, but we're looking at the transcriptomics of the biopsy. So when you have hydrogen sulfide, your gut is a mess. I mean, the kind of things that the cells are trying to do to get rid of the hydrogen sulfide, which is really toxic, are hurting you. When you have methane, it's a different transcriptomic profile. And I'm not going to say what it is, but it's a little scary in some respects because there's a paper that just came out that says methane can be associated with colon cancer development. That's a very beautiful paper that was just published, not our group, another group. And then in terms of the histamine with Klebsiella, that's unfolding as well. So we're going to understand these subtypes much more clearly because we precisely know with shotgun sequencing who the bad actors are, and then precisely determine how they're making your immune system react badly, how they're making you react to food badly, which I know that's a big part of your life. And we're getting there. We're now that we know, we can get there more quickly and start to really understand how these patients are feeling and why they're feeling that way. I'll say one thing is that eh, I know I'm a little long-winded, but one of the things that shotgun sequencing has taught us is, that doctors used to, I don't want to say make fun, but say, "Oh, the patient told me, hey, 10 minutes after I eat, I'm all bloated. Ha ha ha, that can't happen." And what we now know with these two organisms, E. coli and Klebsiella, these guys are Ferraris. They're Ferraris that can ferment food faster than any other microorganism. And when you have SIBO, you're 63 times faster at fermenting than a microbiome of a normal person. So, yeah, you can have bloating 10 minutes after eating food if you have these Ferraris burning through those food calories. So just because we don't understand what the patient's going through and their life experience, we shouldn't be sort of saying, well, that can't be. They're just saying that. They're just being exaggerating their symptoms. I listen to my patients. This is what they tell me. I got to figure out why they're telling me this and why they're right. Because the patient's right. I don't live in their life. They live in their life. And you got to believe your patients.
Absolutely. And when you say like they're fermenting and there's this gas production, I know we talk about the gas a lot, and in the gut health space, I say it broadly, right? There's always the positive side of like, well, good microbes, feed on fibers and foods, they produce gas, they produce all these good byproducts. These players that you're talking about, like they're producing lots of gas, which is definitely contributing to symptoms, but they're also producing things that aren't necessarily great, right? And so they're taking almost the food away from these positive microbes,
Right.
which could be that role of like the negative, I guess, gut health that we see in some of our patients, even though they've got microbes fermenting, but it may not be the right microbes fermenting, which then creates a whole nother picture in patients over
Exactly.
time.
Exactly.
Um,
And they're both, and because they're Ferraris, they're always winning the race, right? You've got a bunch of Ford Escorts, which is what you're supposed to have in there. A nice group of Ford Escorts just kind of cruising along the highway, all at the same speed, all working together. And then you got the Ferraris who are just blowing everybody out of the water. And because of it, they destroy the rest of the microbiome. But when you get rid of those two characters, the microbiome heals. It all comes back to normal quite quickly, which is why rifaximin really isn't an antibiotic. It's getting rid of the bullies, the two bullies that are dominating and eating everything, leaving nothing for the rest of them. But you're right, fiber, they're going to go through fiber faster than the rest. So yeah, that's why the diets are so different for IBS. Everybody says, well, you have to have good bacteria and you have to have fiber to get the short chain fatty acids and all the good things that your colon needs. Yeah, for normal people. But for SIBO patients, that is not the right treatment. That's making things worse for them because they're just feeding the Ferraris.
Now for a quick word from our sponsors with resources that might support you. As someone with IBS-C, I've struggled with symptoms related to food for the majority of my life, specifically FODMAPs. My personal triggers, beans, dairy products, garlic, and onion, would leave me feeling bloated and uncomfortable after meals, especially whenever I was eating out or traveling or living my life outside of my home, which meant I either had to just deal with the symptoms or eat bland, awful food and miss out on experiencing the social interactions and the joy of food. Finding FODzyme was a game changer for me. This is an enzyme blend that targets FODMAPs, specifically the GOS that's found in beans, fructan in the garlic, onion, wheat, and even different fruits and vegetables, as well as lactose in dairy products. I stash this in my wallet, my husband's wallet, every bag I own. I take it with me everywhere I go so that I can simply sprinkle it on my meals, eat with confidence, and feel my best after. If you want to try FODzyme for yourself, go to fodzyme.com and don't forget to use the code THEGUTSHOW, all one word, THEGUTSHOW, for 20% off your first order. Are you struggling with bloating, constipation, or diarrhea, and you're still waiting to see your doctor? Take control and get answers with Gemelli Biotech's at-home gut health tests. The Trio Smart Breath Test is the only at-home test that is validated to look for all three gases that are associated with microbial overgrowth: hydrogen, methane, and hydrogen sulfide. That means it can detect SIBO, IMO, and ISO in one simple test. It ships right to your door, no appointment needed. You take it and you send it back, then you get answers. If your IBS symptoms started after a stomach bug or food poisoning, it could be post-infectious IBS. The IBS Smart Blood Test is a quick at-home test to help identify it. Fun fact, 1 in 9 people who get food poisoning will end up with post-infectious IBS, and most don't even know they have it. With both of Gemelli Biotech's tests, you'll get clinically backed results in about a week, and you can take them straight to your provider. No waiting, no referrals, just answers. Find out which tests are right for you at getgutanswers.com and use the code AaronJudge25, all one word, AaronJudge25, to save $25 on your order. You can also find all these details in your show notes. And now let's get back to the show.
Great. And that leads us right into treatment because we have a lot of questions about it. And I think we can start maybe ground level up, but what we had known about treatment, right, was rifaximin for SIBO, add on neomycin, maybe for methane. update us on the antibiotic side of treatment currently and where
Right.
we stand.
So rifaximin is FDA approved for IBS. So that's IBS-D, IBS with diarrhea, on the basis that IBS was in part a microbiome disease. Now in 2025, 10 years after that approval, we do believe SIBO was the reason for is the reason for the effect of rifaximin. But there's three types of overgrowth. There's SIBO, which rifaximin is what I use. IMO, intestinal methanogen overgrowth. Methanogens are archaea. They're not bacteria. So these antibiotics that we have are antibacterial, not anti-archaeal. I hope that I'm not confusing your listeners. But so that's a totally different group of microbes. So we had to test different antibiotic combinations, different antibiotics in test tubes to see which would be best. And we found that neomycin with rifaximin was best for methane. So we did a double-blind study, and the double-blind study proved that rifaximin and neomycin is better for methane. For hydrogen sulfide, we have a study coming out that we're presenting at DDW with a new drug, totally new, that is better than rifaximin alone. That I can't talk about yet. However, what I can say is what we do in practice today for hydrogen sulfide is we know Pepto-Bismol inhibits hydrogen sulfide producers, and we give that with rifaximin in my clinic for 2 weeks.
Perfect. And someone did ask about the new stuff coming out at DDW.
Yeah.
You guys are usually really great at sharing updates as you go later on and all of that. I will also be sharing on Instagram stories because I will be looking for that at DDW, but I know that that will be coming out and we'll try to pull that into the session in your portal. I'll try to pull those links as we have them. So we have our antibiotics. What if, so a few people have asked about rifaximin, the pricing of it, why is it so expensive is a big question, but also if it's not being covered or if a doctor's not prescribing it for some reason, usually I think that's due to lack of coverage. Is there actually a counterpart, like a replacement for that? What would you say about that kind of part of the treatment puzzle?
Well, you've touched on a number of things that are troublesome. There are physicians out there who don't want to do a breath test still, who don't want to use rifaximin for reasons I don't understand because it's FDA approved, and who still give, for example, tricyclics or these antidepressants. And I'd like to cover a little bit of all of that, but specifically rifaximin, the price, I have no control over that. It's unfortunate. A lot of prior authorizations. We go through it with our patients as well. And so it is a problem. Maybe rifaximin will become generic in the next couple of years. It seems to be heading in that direction. So I'm hopeful that that will be of good benefit to patients at some point that way. But your doctor has to be willing to give it to you. And that if they are not, that's kind of unfortunate. But the alternative that doctors are using are tricyclics. Tricyclics are antidepressants, and they're basically treating the brain-gut axis, is sort of how that's how it's proposed. But really, tricyclics are constipating. So it's no different, in my view, than taking Imodium, except that about 1 in 18 people, based on our harm study, so out of 18 people who took a tricyclic, one person had to stop because of a side effect. And I'm talking drowsiness, dry mouth, palpitations, arrhythmias of the heart, etc., etc. So if your doctor is giving you a tricyclic, you might want to get an EKG. Make sure you don't have any of these risk factors for arrhythmias. The number of people you'd have to treat for one person to stop the drug with rifaximin is 8,971. That's compared to 18. So the safety of rifaximin is very, very safe. And we're presenting an updated version of that harm study that we published now a number of years ago at DDW as well. And I'll give you more on that because there are some new drugs that aren't so great either, not doing so great. But the things that we're presenting at DDW, just for the folks online, we have a new drug that blocks methane. First time we're releasing data. We have a drug that works better than rifaximin. It's a plenary session at DDW. The elemental diet, which we may or may not cover today, is gangbusters good for IBS and SIBO. And then we are in the midst of developing a drug that's going to get rid of the vinculum antibodies of the bloodstream, which is the food poisoning antibody that causes this whole thing. And maybe we don't need any of this other stuff after. Maybe we cure IBS, hopefully, if we're lucky. So, knock on wood, a lot of resources needed to get to that point, and we're working through that as well.
That is extremely exciting. I definitely want to get to diet. So I'm going to run through a few more of the medication questions just so that we have some updates there. Any updates on statins or seaweed-based treatments? I know you guys were looking at statin for methane and it didn't turn out well. Is
Yeah.
that correct?
So the statin drug works, but it doesn't work enough. So the patients had to take higher doses, and there was a lot of muscle aches, which are typical symptoms of statins. And so it didn't work to the level where we had hoped it would. We still give statins to some of our patients, and it's helpful to reduce methane. And the seaweed is interesting because there's a special Hawaiian seaweed, a red seaweed, that can drop methane. And then people caught on to it, and then they wanted to give it to cows. And so they started harvesting some of this. And then Hawaii said, stop it. This is an endangered seaweed. You can't start harvesting all our seaweed from Hawaii and shipping it out. And so a company in Oregon is growing a cousin, I think maybe, of this seaweed and trying to farm it in the ocean off the coast of Oregon. But I don't know how much they're farming, and they're using it for cattle at the moment. There are some people who were able to get the Hawaiian seaweed and it was effective, but it's very difficult to get now. So that's the seaweed story.
Okay, great. We need something that'll last. What about ivermectin? I've seen that been like coming around a lot lately as well as a
Yeah,
question.
I've never used ivermectin for any of this, so I can't say whether it does or doesn't, and I've never seen a study on it. So I apologize if I missed something.
And then the question, because you mentioned, with methane, it's important like having that pairing with like the neomycin and now maybe another option, and then possibly on the hydrogen sulfide, there may be a combo option or something else there. What about when either like the side effects of neomycin? A lot of patients are very hesitant to add that on. Some doctors are hesitant to add that on. And so many people, as of today, might be treated for methane overgrowth with just rifaximin. Is that still effective? And this might lead us into the diet conversation of other combo ideas, but is that as effective? Is there kind of a waste of treatment? Like, should you do the combo? Kind of updates on that piece.
Yeah, so if you don't do the combo, your likelihood of getting rid of methane is quite low. It's about 20%. If you do the combo, it's closer to 70%. So the combo really makes a big difference. People are concerned. I don't want to make a long-winded answer again because then you won't get to your questions. But neomycin's an aminoglycoside. Aminoglycosides, like gentamicin, intravenously for long periods of time, which used to be treating endocarditis, an infection of your heart valve. If you take an aminoglycoside in your blood through an IV for 3-4 weeks, you can get ringing in the ears and hearing changes. Neomycin is 95% not absorbed, but it is an aminoglycoside. And because it is an aminoglycoside, the FDA has to label it with hearing difficulties. And so people are concerned about neomycin, but it's not absorbed. And so we've never seen any hearing issues with it. But if you have hearing problems, I don't use it. And I would use metronidazole with rifaximin instead. And we don't have a study, but in our clinical practice, it works just as well. So rifaximin plus metronidazole is an alternative to the neomycin. Hopefully that answers your question.
Wonderful. Yeah, I want to get to the other pieces. I know there's so many questions on treatment specifically, but the elemental diet, the diet link, because you guys presented that kind of initial research at DDW last year looking at elemental diet and methane. A lot of people may not know what that even means. So briefly, what is the elemental diet? What have you found? And then hints towards what now, how that's expanded
Yeah.
in the role that it will play.
Well, the original idea of the elemental diet I came up with in 2004. So the elemental diets have been around since the 1970s. And my idea was, I had patients back then, we didn't have rifaximin. We were going through antibiotics and people were getting resistant to them with their SIBO. And so we didn't want that. So I said, well, elemental diet gets absorbed so quickly by the human, the bacteria don't have a chance. They don't have, or they get less calories. So could we treat overgrowth with elemental diet? So we started with a product called Vivanex, which is from Nestle. And we showed that, yeah, you can get rid of overgrowth in patients where antibiotics failed. And that study was published in 2004, and we've since done a few thousand patients with it, and it's pretty reliable, but it tastes awful. And Vivanex is really good if you want to get it fed through a tube, but drinking it is not fun, and you get a lot of yeast in the mouth and all sorts of stuff. So working with a different company, we've come up with a formula that tastes really good. And I've actually drank it for 7 days just to see what the patient experience would be like. I didn't do the full 14, but I did 7 just to see. And it tastes really, really good, and people can do it. And so the elemental diet has come back into favor for treating overgrowth. Almost every single patient who in the study, which is published this week, by the way, in CGH, Clinical Gastroenterology and Hepatology, who took it, who have SIBO, got rid of it, at least temporarily until it comes back. And methane was about, I think, 67%, 70% in that range. So that's pretty darn good for methane, especially since they failed other things for their methane in a lot of cases. So elemental diet, you can treat SIBO with diet. Who knew?
It's always positive to have options, especially for people who, you mentioned relapse, and a few people have asked about that of like relapse is known to be pretty common. And I know
Yeah.
obviously if we can get to that cure, like that may solve that problem. But what are you thinking? So you do antibiotics, there's relapse. The antibiotics again, there's relapse. Maybe you try diet, there's relapse. Like, what do you consider, like, what are you thinking about in these patients who are getting relapse often? And is there any way for patients to prevent relapse? Like, is there
Yeah.
anything that you've found that works?
So what I do for my patients who relapse is they go on the treatment, whatever treatment worked for their SIBO, IMO, ESO, they get treated, they get to that good place, and then we implement diet and a prokinetic. So we use the prokinetic to trigger or stimulate the cleaning waves of the gut, and we use Motegrity or low dose erythromycin. That's what I do. A low dose of Motegrity every night on an empty stomach, and you'll get cleaning waves through the night. Strip out all the junk from the meal that you couldn't digest, so the bacteria don't have, they're not sitting around all night munching and growing and multiplying. We clean that out with the cleaning waves because you don't have cleaning waves that much, so that's why it's important. The diet I use is the low fermentation diet, which we created back in 2005, well before the low FODMAP diet. Not as much data on it, but if you've heard any of my talks, if you heard me ever speak, I'm patient-centric in the way I approach what I do. I want my patients to go to a restaurant, not be afraid, sit with friends, sit down, look at the menu, and find something without questioning the waiter. I want them to go to the restaurant, not have diarrhea, get on a plane, not put their seatbelt on, and worry about now they have to have diarrhea, but they can't take their seatbelt off. They can't go. All those miseries of social life that people have. And so the low fermentation diet is not as restrictive. Therefore, you don't get nutritional deficiencies. But I can almost guarantee any restaurant in the country will have something on the menu where you don't have to spend 5 minutes asking the waiter, does it have this? Does it have this? Does it have this? As some diets do. Because your friends don't want to hear you talking to the waiter for 5 minutes, and it's embarrassing. It's hard for you. So that was the decision. And the second part of it is the low fermentation eating is the composition of the diet, but also spacing your meals, allowing the cleaning waves, because you need cleaning waves. We can't be eating all day. We never did. 1,000 years ago, we didn't have a 7-Eleven. We didn't have chips. We didn't have bagels in the break room 1,000 years ago. We ate and then we didn't eat, allowed the gut to clean itself, and that's really important.
Great. And then what about probiotics in this mix as well? And I'll throw in fermented foods too, because then
Yeah.
people ask about that often. Is there a role during treatment? Is there a negative part of their function? Like, where do they fit in?
I can say a lot of things about probiotics because of our shotgun data and a lot of the research that we're doing here. Probiotics are not helpful for IBS. If you look at the IBS meta-analysis and you take every single probiotic study ever done, on every single different probiotic from lactobacillus to bifido to E. coli itself, E. coli Nissel, and smoosh it all together, you get a small signal. Maybe it's helping a little bit. But if you look at any individual probiotic, let's say lactobacillus in general, it's not statistically significant, and there are many studies. And then you go to our reimagined data, and we show that in the elderly, so unhealthy aging is associated with higher lactobacillus of the types that you would take in a capsule in the small bowel. And those same types are also associated with obesity in our obesity study we published. So putting it all together, probiotics ferment. So they're going to need to make gas because that's how they eat and produce gas. So, and somebody who already produces gas doesn't clean up their small bowel cleaning waves. They're going to just accumulate these things. And then all the other negative sides of lactobacillus. I'm not so excited about lactobacillus, so I never give it to my patients.
And then I'll ask one quick question myself, and then we're going to go through rapid fire, as many of the ones
Okay.
I could get to from everyone else. But you mentioned this, so we're going to throw it in. The role of metabolic disorders and the overlap with SIBO. I know your team has done such a good job at kind of looking at both, like the endocrinology side as well. So PCOS, diabetes, these different metabolic conditions. Is it chicken or the egg here? Like, is it that the gut side is influencing the metabolic side? Is it that the metabolic side is influencing what's going on in the gut? Like, is there anything kind of clear that's connecting these? I know a lot of IBS patients also deal with diabetes, PCOS, like these different metabolic disorders. So curious.
So I'll try to do this quickly so we can go to rapid fire. But methanogens and methane slows your gut down. If you have more time, you absorb more calories. You absorb more calories, no surprise, higher body weight. Methanogens, methane is associated with higher body weight and even obesity. In obese populations, they have a 7-point higher BMI. We've published all of this. If you talk about PCOS, we found a bacteria. This is not SIBO. This is a bacteria that produces testosterone. We presented this last year at the Endocrine Society. When we take that bacteria, if you want to talk about cause and effect, and we put it in rats, they get PCOS, they get cysts in their ovaries, they get higher testosterone, they get irregular menstrual cycles in the rats. So it's not you dictating the organisms, it's the organism dictating you. And we're doing a lot more work on that organism. It's a separate area of research in endocrine, but there are a lot of downstream consequences of the microbiome in the gut and how it's metabolically affecting you. And we talk about even the microbiome gut-brain axis. There are bacteria in the gut that produce serotonin. There are bacteria in the gut that trigger you to produce substance P, which is a hyperalgesia chemical that makes your nerves more bioactive. But these bacteria are not going to your brain. This is not a brain disease, the IBS. I'm not convinced of that. I don't think the data convince me of that. This is not in your head. What's going on is a food poisoning triggering all these downstream bad consequences to you. And we're working very hard to get the drugs necessary to remedy it. But it's going to be 60% of IBS, unfortunately. It's not the whole enchilada, but that's a big chunk. And we hope that'll help a lot of people.
Absolutely. And it will help make sense of the rest of the pieces, which is ideal. So rapid fire, you could not answer this if you don't want to, but will your work be affected by the cuts that are happening with the federal government? Is that a problem?
Absolutely. Absolutely. A lot of things are going to go, everything's going to go slower. People have been waiting many years for us to get to this point, but from here on, things are going to move more slowly, just funding. This is the way we're.
It's unfortunate. How can I get an appointment with Dr. Mark or your team? How can people come and see you and work with you guys?
So we have 6 amazing motility specialists here. So it doesn't have to be me because it's very hard to see me because there's only one me and 45 million IBS patients in the United States. So we are kind of overwhelmed a lot because we're doing good work and we're trying to help people. But it's hard to see me, but it can be done sometimes.
Okay. And then what about the elemental diet causing more symptoms and an increase in hydrogen and methane? There's been a couple of people that asked about that. Is that common? Is there a reason for that?
I haven't seen the new Mbiota product do that. Is it possible if you check the 1,000 patients? Maybe, but we haven't seen it in our practice yet. So I'd need to know more information to kind of understand what's happening in that particular individual. I'll say just one thing very quickly. Remember, SIBO can be caused not just by IBS, but by adhesions and other conditions. So people who don't respond to therapies in a typical fashion, we start looking for those other things. So that might be why that they had this effect.
Great. How often do you see endometriosis, especially in like the methane, like constipation space?
We don't
In the
see that they're
purple.
necessarily associated in the sense that SIBO is causing endometriosis or contributing to endometriosis, but endometriosis can affect the bowel, can wrap around the bowel, and then can cause constrictions or changes in motility that can lead to overgrowth. So we do see that.
Great. We've talked a lot about IBS. What about GERD, like the upper part of the GI tract? Because small bowel's right in between. So what do we know about GERD, reflux, and SIBO?
Well, we have a abstract at DDW. I know, right? You're covering all the topics that I'm going to give you such amazing information in about a month. But there is a difference in the microbiome in GERD, and it has a little bit to do with hydrogen sulfide, but you'll hear more about that in a month. But yes, GERD, dyspepsia are linked to SIBO as well, because the more gas you produce, the more pressure you produce. The more pressure you produce, the more reflux you have. So there's an interlink, and there may actually be a physiological link in terms of cause and effect too that needs to be explored.
Interesting. Prior to the elemental diet, does it make sense or do you recommend a cleaning protocol? So like a colonoscopy prep of clearing out all the stool, like clearing out the bowels before you do elemental diet, or I guess we can say any treatment.
Well, what's funny in that question is no, I don't recommend that. I don't recommend doing that before you go on elemental diet. But before we had all these antibiotics, patients would say, "Oh, I had a colon prep and my IBS was better for 3 weeks." These doctors who are like 90 years old come to my programs and they said, in the 1970s, they gave a patient Flagyl and they IBS went away for like 6 months. So I believe what you're saying, because they would see these things, but they wouldn't understand them then. And I shouldn't have used an old person's voice because I'm getting old too, and somebody's going to say something. But yes, these things were recognized, and colon prep can make a person feel better temporarily.
Great. The only thing someone has said, which I think you should take as a massive compliment, there's been a couple of comments about Jeff Goldblum giving the talk on SIBO. So
Well,
if you're
I
compared to Jeff Goldblum,
I
that's
I've been on a cycle of fitness, and so I've lost a bit of weight. And people used to call me Ray Romano looking. Now I look more like Gaunt, like Jeff Goldblum, and the glasses. So my wife sort of thinks I look like Mark Pimentel, but
yeah.
not Jeff Goldblum. Yes, but I've
Yeah.
heard that before.
That would be fun to bring him in. Someone asked about LDN, and we talked a little bit about the immune side. Low dose naltrexone. I know that's in the functional medicine space. That's gotten really hot in the SIBO world. What do you think about the use of that in this patient population?
Yeah, so this brings me to an important point that I wanted to make earlier and I didn't. Low-dose naltrexone is effective. It has a motility effect and it has a anti-inflammatory effect. So yes, people are using it. I've used it. In comparison to Motegrity, it's a very modest treatment. So it's not as zesty or as effective as I would like it in my practice. I'm seeing it in some of the tougher patients. But I think one thing I want to say very quickly is that SIBO is, I don't want it to be a popular disease. I want it to be an accurate disease. And I think what happens when people start really noticing that they have SIBO and getting diagnosed, it becomes popular and then overpopular. Uh, we're going to keep working with the science. We're going to keep following the science, and we're going to keep following the data, and we're going to get this better. But I don't want this to be overplayed because there are people where they think they have SIBO and they don't. So,
Great. Now, I want to use your last minute because this is a fantastic question. How do you navigate through the conversation when patients are desperate or hyperfixated to find the etiology of the SIBO, IMO, ISO, IBS? How do you navigate that while also still helping them advocate for figuring out what's going on?
so it's a philosophical answer. Okay. And I use this example. If patients go to a doctor, let me start again. Because this disease is so nebulous, and it has been so nebulous, and people have been saying it's in your head, here, take an antidepressant, here, go do yoga, here, go see a psychiatrist, and none of that's helping. And you're like, I don't have depression, I don't have any of this stuff. There's a lot of self-help. So patients are out there looking, being their own doctor. Okay. And when people come to my clinic, I tell them, one of the things I say to them, I say, relax. I got this. I'm going to help you through this. I'm going to give you the best guidance I can. Will we find all the answers? Not always. Will we work our ass off to try to get you the answers? I won't stop till you want to stop. I'll keep trying to find the answers if we keep getting stuck. You have no idea the pressure and relief taken off that patient, because they think they're their own doctor, because nobody's advocating for them. And you have to do this. You have to take over, and give the patient confidence that you know what you're doing, and you're going to work for them, because that's your job. You're going to work for them. They shouldn't be their own doctor. That's not fair. They're anyways. So that's what I tell them. It may not be SIBO, but we're going to try our darndest to figure out what it is and get you better.
Wonderful. Great way to wrap up. But Dr. Pimentel, thank you so much for your time. This was incredibly informative. I'll be there at TDW, so I'll be snapping all the info and sharing it with everyone as much as possible. And we look forward to hearing even more from you and your team. But thank you for your time today.
Are you listening to today's episode with the main thought being, what are the steps that I can take to get rid of my symptoms right now? While I hope that the information that we share in every episode of The Gut Show leaves you feeling more empowered and more confident in your body, it's not always going to solve your problem or give you a clear direction for your specific symptoms and your needs. The Master Method membership is an online program for the person with chronic digestive symptoms and IBS who wants step-by-step guidance to understand their body, address the drivers of IBS, reduce symptoms, and build resilience in your gut long-term. This membership includes a step-by-step course and a dietitian-led community that teaches you how to holistically address each symptom and the IBS drivers, how to reduce symptoms more strategically and with confidence, and guidelines for better gut health long-term so that you're not only thinking about today, but you're also improving your outcomes in the future. It is time to ditch the symptoms and get your life back. The membership is your first step. You can learn more and enroll at ibsmastermethod.com and use the code GUTSHOW, GUTSHOW, GUTSHOW for $25 off your enrollment fee.